Assalamu alaikum. I am Dr. Atif Raza and you are watching Pediatric Health Channel for professionals, that is Peds Mentor. In part 1 and 2, Approach to Neonatal Cyanosis, we deal with basic approach and mastering the management of RDS and PPHN. That is how we found the lungs pathologies for cyanosis. Now, this is the part 3 of the lecture series Approach to Neonatal Cyanosis, that is the blue baby. In this part, we face the heart. Because congenital heart disease is the most common birth defect. But there is one group that terrifies every NICU team, the ductal dependent lesions. Because these babies are born with a countdown clock inside their chest. That is, they have patent ductus arteriosus, which is their life. A baby with transposition or hypoplastic left heart can look completely fine at birth. This is because the ductus arteriosus is still open. So it is allowing blood to mix or bypass obstruction. But at 24 to 72 hours, that ductus start closing. So in ductal dependent lesions, patent ductus arteriosus is the lifeline because it bypasses the obstruction and allows blood to mix. But at 24 to 72 hours of life, it starts to close. And when it shuts, the lifeline is cut. So the baby crashes. Your job is to suspect the defect before the crash. So today we map out the 5 T's, the grey babies, and the single bedside principle that saves lives. So we all know the mnemonic, the 5 T's, which is basically for transposition of great arteries, Tetralogy of Fallot, tricuspid atresia, total anomalous pulmonary venous return, and truncus arteriosus. But out of these 5, 3 of them will define your boards and your night shifts. So here we discuss only transposition of great arteries, tetralogy of Fallot, and total anomalous pulmonary venous return. So starting with the first one, that is transposition of great arteries, that is TGA. This is the number one cause of cyanosis in the first week. Where is the problem? Here the problem is basically in the circuit. The circuits are parallel. It means the right ventricle pumps blood back to the body. And the left ventricle pumps blood back into the lungs. So if I draw a circuit, just look at this diagram. This is the right ventricle and this is the left ventricle. Normally, right ventricle is connected to lungs, and left ventricle is connected to body via aorta, and this is via pulmonary artery. But in transposition of great arteries, there is a defect in this circuit. Here, aorta arises from right ventricle and pulmonary artery arises from left ventricle. So, right ventricle have deoxygenated blood which normally pumps into lungs for oxygenation, and this oxygenated blood pumps into left atria and then left ventricle, and this oxygenated blood is pumped into body. But in transposition of great arteries, right ventricle is connected to aorta. So here is the deoxygenated blood. So this deoxygenated blood is pumped into aorta and then from here to body. So body receive deoxygenated blood. But when this patent ductus arteriosus is not shut or it is patent, there is shunting of blood. So mixed blood is pumped into the body in unit in the first 72 hours. But when it closes, it results in a havoc. So the survival of this baby is dependent on this shunting. That is, here ductus arteriosus should remain open for shunting of blood so that mixed blood is pumped into the body. So they must have a patent foramen ovale or patent ductus arteriosus. For TGA, X-ray of chest looks like an egg on a string. So it just look like this on X-ray. So this one is the first one, that is TGA. The second one is Tetralogy of Fallot. In Tetralogy of Fallot, this is the number one cyanotic lesion overall. This is the number one cause of cyanosis in first week, and overall the number one lesion is top. Here the problem is basically right ventricular outflow obstruction. So as the right ventricle is obstructed, let me draw a diagram. This is pulmonary artery which is stenosed. So there is obstruction in right ventricular outflow. So when there is obstruction, the blood can't reaches to the lung for oxygenation. So it shunts right to left through the VSD. So there is shunting of blood via VSD. So Tetralogy of Fallot have pulmonary artery stenosis, overriding of aorta, and ventricular septal defect. What about the X-ray? Here X-ray looks like boot shaped. So here the heart is boot shaped. just like this. Now the third one, that is total anomalous pulmonary venous return, that is TAPVR. This is a plumbing disaster. The pulmonary veins do not connect to the left atrium. So here pulmonary veins are not connected to left atrium. They drain into the superior vena cava or the liver. So pulmonary veins are not connected and they drain into SVC or liver. The main purpose of pulmonary veins is to bring back oxygenated blood into left atrium and then from here to left ventricle and then here into body through aorta. But as these veins are not connected with the left atrium, so there is cyanosis due to deficient oxygenation of blood which is flowing through the aorta. What about the X-ray clue? On X-ray, heart looks like a figure of 8 or just like a snowman. If TAPVR is obstructed, the lungs white out. It looks exactly like pneumonia. So if a pneumonia baby fails to improve, remember, things TAPVR. So here, obstructed TAPVR just look like pneumonia because the lungs white out. And if you are treating baby like pneumonia and it is not improving, always think for TAPVR. These are the ductal dependent lesions. Now move toward the gray babies. That is Hypoplastic Left Heart Syndrome or critical coarctation. So two more conditions of heart which results in cyanosis are severe coarctation and hypoplastic left heart syndrome. As the left heart sided heart or left ventricle is severely hypoplastic here, so left ventricle cannot pump blood into the body. So here left ventricle is hypoplastic, therefore it cannot pump blood into systemic circulation, resulting in gray baby. The only way the systemic circulation survives is the right ventricle through the patent ductus arteriosus. So as the left ventricle is hypoplastic and there is severe coarctation, so here the survival is only through the patency of ductus arteriosus. Ductus arteriosus should remain open. When the PDA closes, that is after 72 hours, day 3 to 5, systemic flow stops, pulses disappear, lactate skyrockets, and there is cardiogenic shock. If you cannot feel femoral pulses in a sick neonate, it is coarctation until proven otherwise. So, the importance of PDA is here, and in all these conditions, PDA should remain open in these children for their survival. When the PDA closes, In HLHS or severe coarctation, the femoral pulses become absent. So remember, if you cannot feel femoral pulses in a sick neonate, consider coarctation until proven otherwise. So these are the five conditions which are mostly asked in your board examination, that is transposition of great arteries, tetralogy of Fallot, total anomalous pulmonary venous return, critical coarctation, and hypoplastic left heart syndrome. So we have these conditions, and the only survival is dependent on one drug, that is prostaglandin E1. So if you look at the management is dependent on prostaglandin E1. So if you think any of this lesion in any neonate and you think that these lesions are present, start prostaglandin E1 without confirming it, because if patent ductus arteriosus closes, your countdown stops. So we give prostaglandin E1 at a dose of 0.05 mcg per kg per minute. But here is the advanced NICU concept that saves life. Remember, do not flood the lungs with 100% oxygen. In single ventricular physiology, blood flows to the path of least resistance, and we know pulmonary resistance is low and systemic resistance is high. So if you blast the baby with 100% oxygen, you dilate the pulmonary vessels. All the blood rushes into the lungs and it steals flow from the body. The baby turns pink but dies of systemic shock and acidosis. So, if you give 100% oxygen, the blood flows into the pulmonary vessels, resulting in systemic shock and acidosis. Systemic shock and acidosis. So you have to keep the target SpO2 in between 75 to 85%. So remember one rule. In suspected hypoplastic left heart syndrome, room air is your friend. Avoid 100% oxygen unless they are coding. So here's the truth. The heart lesions are the nightmares we fear most. They crash fast. They demand prostaglandin now. But once you have ruled out all of them, once the echo is normal, but the baby is still cyanosed, your job is not done. Because some of the deadliest blue babies are not cardiac at all. So, in part 4, we finish this series with the hidden killers, that is, the blood, the brain, and the great imitator, that is sepsis. So, stay sharp because a normal echo does not mean a safe baby. See you in the final lecture when heart and lungs are normal but the baby is still blue. So that's all about the today's lecture, that is approach to neonatal cyanosis. the Blue Baby Part 3. Here we dealt with the ductal dependent lesions, that is TGA, Tetralogy of Fallot, TAPVR, HLHS. And in all these scenarios, we have a single management plan, that is to keep the shunting open so that mixing of blood can occur and the baby can survive. But you have a very narrow window to act. So start vigilantly to keep your neonate alive. These videos are only for educational purpose. If you have any query, ask your query in the comment box. I hope you have a crystal clear concept related to this. Till part 4, Allah Hafiz.